Hello and welcome to the topic Ulcerative Colitis in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define ulcerative colitis, explain the pathophysiology of ulcerative colitis, explain the clinical presentation of a patient who presents with ulcerative colitis, outline the investigations in the diagnosis of ulcerative colitis, and finally discuss the management of ulcerative colitis. Let's get started. Ulcerative colitis is a long-term condition that results in inflammation and ulcers of the colon and rectum. Ulcerative colitis is a condition in which the lining of the large intestine and the rectum becomes inflamed, and it is a form of inflammatory bowel disease. The exact etiology of ulcerative colitis is unknown, but the disease appears to be multifactorial and polygenic. The proposed causes include environmental factors, immune dysfunction, and a likely genetic predisposition. In ulcerative colitis, a leading theory is that the immune system mistakes friendly bacteria in the colon, which aid digestion, as a harmful infection, leading to the colon and rectum being inflamed. An increased amount of colonic sulfate-reducing bacteria has been observed in some people with ulcerative colitis, resulting in higher concentrations of the toxic gas hydrogen sulfide. The inflammation caused by ulcerative colitis affects the mucosa and the submucosa, and there is a sharp border between normal and affected tissue. Only in severe disease is the muscularis involved. Early in the disease, the mucous membrane is erythematous, finely granular and friable, with loss of the normal vascular pattern and often with scattered hemorrhagic areas. Large mucosal ulcers with copious purulent exudate characterize severe disease. Islands of relatively normal or hyperplastic inflammatory mucosa project above areas of ulcerative mucosa. Fistulas and abscesses do not occur here. Ulcerative colitis usually begins in the rectum. It may remain localized to the rectum, known as ulcerative proctitis, or extend proximally, sometimes involving the entire colon. Rarely it involves most of the large bowel at once. Symptoms of ulcerative colitis include blood in the stool, rectal bleeding, frequent stools, mucus discharge from the rectum, tenesmus, lower abdominal pain, and severe dehydration from purulent rectal discharge, in severe cases especially in the elderly. Rectal pain, rectal bleeding, urgency to defecate, and inability to defecate despite urgency. The primary symptoms of active disease are abdominal pain and diarrhea mixed with blood. Weight loss, fever, and anemia may also occur. Often, symptoms come on slowly and can range from mild to severe. As for the signs, try not to miss out anemia, diarrhea often with blood or pus, abdominal tenderness, weight loss, and fatigue. You may also encounter other hallmark or additional signs that are associated with ulcerative colitis, such as dehydration due to the severe bleeding and diarrhea, eye irritation, which are other associated features that can come along with ulcerative colitis, and also night sweats. As for lab tests and endoscopy, we look at blood specimens. A full blood count is done to check for anemia or thrombocytosis, which is occasionally seen. Electrolyte studies and kidney function tests are done, as chronic diarrhea may be associated with hypokalemia, hypomagnesemia, and kidney injury. Liver function tests are performed to screen for bile duct involvement, especially in primary sclerosing cholangitis, and inflammatory markers such as erythrocyte sedimentation rate or C-reactive protein. Stool culture and Clostridium difficile stool assay is done to rule out infectious colitis. And as far as histology is concerned, biopsy sample that demonstrates marked lymphocytic infiltration of the intestinal mucosa and architectural distortion of the crypts. Biopsies of the mucosa are taken during endoscopy to confirm the diagnosis of ulcerative colitis and to differentiate it from Crohn's disease, which is managed differently clinically. Histologic findings in ulcerative colitis include distortion of crypt architecture, crypt abscesses, and inflammatory cells in the mucosa. Unlike the transmural inflammation seen in Crohn's disease, the inflammation of ulcerative colitis is limited to the mucosa. These are examples of imaging studies and functional tests that can be conducted. X-rays or CT scans may be helpful in assessing complications of ulcerative colitis such as perforation or toxic megacolon. Bowel ultrasound is cost-effective and well-tolerated. Non-invasive and readily available for the management of patients with inflammatory bowel disease, including ulcerative colitis. However, imaging is otherwise of limited use in diagnosing ulcerative colitis. Magnetic resonance imaging or MRI is necessary to diagnose underlying primary sclerosing cholangitis. A lower endoscopy is done to evaluate the rectum and distal large intestine, or entire colon and the end of the small intestine for ulcers and inflammation. Although ulcerative colitis is a disease of unknown causation, inquiry should be made as to unusual factors believed to trigger the disease. When it comes to treatment, we can begin with medications, drugs such as 5-ASA or aminosalicylates. Ulcerative colitis can be treated with a number of medications, as mentioned, sulfasalazine and mesalazine. Corticosteroids such as prednisolone can also be used due to their immunosuppressive and short-term healing properties, but because their risks outweigh their benefits, they are not used long-term in treatment. Sulfasalazine has been a major agent in the therapy of mild to moderate ulcerative colitis for over 50 years. It was shown that 5-aminosalicylic acid was the therapeutically active component in sulfasalazine. Oral ASA drugs are particularly effective in inducing and maintaining remission in mild to moderate ulcerative colitis. Rectal suppository, foam, or liquid enema formulations are used for colitis affecting the rectum, sigmoid, or descending colon and have been shown to be effective especially when combined with oral treatment. Other immunosuppressive agents also include azathioprine. Thirdly, we can consider biologic agents such as infliximab, adalimumab, golimumab. They are commonly used to treat people with ulcerative colitis who are no longer responding to corticosteroids. Biologics may be used early in treatment as a step-down approach or after other treatments have failed to induce remission, such as a step-up approach. Unlike aminosalicylates, biologics can cause serious side effects such as increased risk of developing extraintestinal cancers, heart failure, and weakening of the immune system, resulting in decreased ability of the immune system to clear infections and reactivation of latent infections such as tuberculosis. For this reason, people on these treatments are closely monitored and are often tested for hepatitis and tuberculosis annually. Next would be transdermal nicotine patch. Unlike Crohn's disease, ulcerative colitis has a lesser chance of affecting smokers than non-smokers. In select individuals with a history of previous tobacco use, resuming low-dose smoking may improve signs and symptoms of active ulcerative colitis. Studies using transdermal nicotine patch have shown clinical and histological improvement. However, nicotine therapy is generally not recommended due to the side effects and inconsistent results. Last but not least, iron supplementation. The gradual loss of blood from the gastrointestinal tract as well as chronic inflammation often leads to anemia, and professional guidelines suggest routinely monitoring for anemia with blood tests repeated every 3 months in active disease and annually in quiescent disease. Adequate disease control usually improves anemia of chronic disease, but iron deficiency anemia should be treated with iron supplementation. The form in which treatment is administered depends both on the severity of the anemia and on the guidelines that are followed. Some advise that parenteral iron can be used first because people respond to it more quickly, it is associated with fewer gastrointestinal side effects, and it is not associated with compliance issues. Others require oral iron to be used first, as people eventually respond and many will tolerate the side effects. Failure of medical management is the most common indication for surgery. Classically, an acute attack of ulcerative colitis that does not respond to intravenous steroid therapy within 10 days warrants surgical intervention. Indications for urgent surgery in patients with ulcerative colitis include toxic megacolon refractory to medical management, fulminant attack refractory to medical management, uncontrolled colonic bleeding, perforation, obstruction and stricture with suspicion for cancer. Indications for elective surgery in ulcerative colitis, on the other hand, include refractory disease with failure of medical management, chronic steroid dependency, dysplasia or adenocarcinoma found on screening biopsy, disease present for 7 to 10 years, systemic complications from medications, particularly steroids, and failure to thrive in children. Surgery has been viewed as definitive therapy for ulcerative colitis in certain situations, and total proctocolectomy is often curative, alleviating symptoms and removing the risk of colonic adenocarcinoma. Ileoanal pouch reconstruction or ileorectal anastomosis is done in an emergency for subtotal colectomy with an ileostomy. So when is surgery contraindicated? The only absolute contraindication for surgery is anal sphincter dysfunction. Pre-existing incontinence due to neurologic impairment or other causes makes reservoir construction unnecessary and makes ileoanal pull-through inadvisable. So in conclusion, we have seen what ulcerative colitis mean, which is the inflammation and ulcer formation in the colon and the rectum, predominantly affecting the lower gastrointestinal tract. We have looked at the pathophysiology and causes and common clinical presentation in patients with ulcerative colitis. We have also looked at the investigations that help us diagnose as well as monitor the treatment response, and finally, indications for medical and surgical therapy. We have come to the end of this session. Thank you.